My name is Amanda Zylak, and I am here to do a transfusion medicine educational session for the Saskatchewan Cancer Agency. Just want to remind everyone of SHA's vision, mission, values, and philosophy of care. We acknowledge that we are gathering on Treaties 2, 4, 5, 6, 8, and 10, territories and the homeland of the Dakota, Lakota, and Métis people. Transfusion safety and patient blood management. Who are we and our focus areas? My name is Amanda Zylak, and I am new to this role as of September. Prior to this, I was an MLT in transfusion medicine for 14 years. I have a counterpart in the north. Her name is Kimberly Goodwill, and we work very closely together to support the whole province. So if I'm ever unavailable, please call her or Jen Lambert. I will give you their contact information at the end. Jen Lambert runs the Regina Transfusion Medicine Department. Her staff do all the complex transfusion testing for southern Saskatchewan, and they send compatible blood to the rurals. Kim and my roles as transfusion safety managers of the province is to support the lab and the staff performing transfusions to promote safe, effective, and standardized transfusion practices across the province. Patient blood management is a very big push coming in the transfusions world. It's an evidence-based multidisciplinary approach to optimizing patient care to those who might need a blood transfusion. It focuses on improving patient outcomes by optimizing their own red cells, such as treating anemia before surgery, minimizing blood loss and bleeding through surgical, anesthetic, and laboratory best practices, and by only transfusion when required based on patients' true hemoglobin thresholds. The goal of PBM is to ensure that patients receive the right care at the right time with the least exposure to donor blood, thereby improving safety, conserving resources, and reducing costs. Part of our portfolio is also the IG Stewardship Program. This program monitors and ensures appropriate use of IVIG. IVIG is approximately $67 a gram, and some patients are on doses as high as 200 grams. Some patients will be on IG for their lifetime, so it's the job of the IG program to taper patients' doses to the lowest possible dose that works for that patient. Transfusion medicine regulations. In Canada, every part of the laboratory is regulated by Health Canada. That's especially true for the transfusion services and the blood products we manage. Because of these regulations, we are required to maintain a full vein-to-vein traceability. So in simple terms, that means that we must be able to track every blood product or component from the donor all the way to the patient, including every step in between. So storage, transport, modification, and final infusion. Hospitals must keep permanent records of which blood products were issued to which patient and when. These records are kept indefinitely to meet national safety and traceability requirements. All of our labs in Saskatchewan are accredited by WCAA, with the exception of Regina, who holds CAP accreditation, which means even more rigorous standards apply there. National and international standards are designed to ensure that every patient receiving a transfusion gets the safest possible product. All our blood components are manufactured by Canadian Blood Services and are collected by volunteer donations. Blood components are separated parts of whole bloods. They include red blood cells, platelets, plasma, and cryoprecipitate. Blood products are mostly purchased by CBS from vendors. Blood products are made by fractionating plasma proteins. They include things like albumin, IVIG, fibrinogen concentrate, and coagulation factors. Blood basics, blood components. Whole blood donation can be broken down into three main components: packed red blood cells, plasma, and platelets. There's another component that can be broken down into called cryoprecipitate, but Canadian Blood Services only makes cryoprecipitate or platelets, and platelets are much more useful, especially when there is a product called fibrinogen concentrate that works the same as cryoprecipitate, if not better. A typical red blood cell unit issued by Canadian Blood Services is approximately 287 mils. 1 unit of red blood cells usually increases the hemoglobin by approximately 10 grams per liter in a 70 kg non-bleeding adult. Blood samples collected from the donor at time of donation are tested for certain transfusion transmissible infectious agents. A big topic lately is vaccines. CBS does not make their donors disclose if they have been vaccinated. So if a client doesn't want vaccinated blood, there is actually no way of finding out this information. Red blood cells are stored at 1 to 6 degrees. Plasma has mostly been replaced in the province by a product called Octoplasma, and it is produced by Octapharma. It is plasma, but it's processed in a different way, so we get the same benefits of plasma, but it's actually a safer product. It comes from Canadian Blood Services frozen and is thawed upon request from the board. Pooled platelets Sorlin treated are pooled from multiple donors of the same blood group. Apheresis platelets Sorlin treated are produced from single donor apheresis platelet donation. Each dose of platelets should increase the patient's platelet count in 1 hour by an increment of 15. Some disease states can decrease the amount of increment, such as sepsis or fever, and platelets are stored between 20 and 24 degrees. Blood group systems. The ABO blood group system is our main category. So you can think of it like the most important and the most basic way to categorize blood. We sort people into 4 big groups: Group O, Group A, Group B, and Group AB. Each group is based on the antigens on the surface of the red cell. So you can see above that Group A has A antigens on the red cell surface and anti-B antibodies in the plasma, whereas Group O has no antigens on the red cell surface, but has both anti-A and anti-B in the plasma. So why is this important? If you give a Group O person a Group A donor unit of red blood cells, the anti-A that is naturally occurring in the Group O person's plasma will bind to those donor red cells and cause the donor unit cells to hemolyze. The problem is the ABO is not the only complexity when it comes to blood compatibility. There are subcategory blood group systems. There are over 30 blood group systems that we test for in transfusion medicine on a regular basis. So just because a person is Group O does not mean that any unit of Group O is necessarily compatible. Patients develop antibodies to these blood group systems by transfusion of red blood cells, pregnancy, and sometimes they're naturally occurring. Sometimes it's easier to understand when you see it in a different way, so here are some depictions of basic ABO compatibility charts. On the red blood cell compatibility chart, you can see that O positive can receive O positive or O negative red blood cells. But O negative can only receive O negative red blood cells. So being O negative is great as a blood donor, but as a recipient, it really limits your compatibility options. A patient that is AB positive, however, can receive all blood types. This is why O negative is the universal red cell donor and AB positive is the universal red cell recipient. In large centers, we will always have ABO compatible blood on hand, and this is why some small centers only carry Group O. O positive is the most prevalent blood group in our Canadian demographic, followed by A positive. Red blood cell compatibility and plasma compatibility are opposites. Patients can only receive AB platelets or plasma products. Group O patients can receive all plasma blood types. As you can see in the plasma platelet chart doesn't include Rh negative or positive. So why do we not care about Rh status in plasma products but we care in red cell products? This is because the Rh antigens are on the surface of the red blood cell. Rh status. On the left, there's a visualization of an O positive person. You can see that they have an Rh antigen on the red cell surface. They have anti-A and anti-B antibodies in their plasma. On the right, we can see an O negative person. There are no antigens on the red cell surface, and there are still anti-A and anti-B antibodies in the patient's plasma. This, however, is an O-negative person with an Rh antibody or an anti-D. Anti-D is not naturally occurring, which is why we don't see it in a regular O-negative person and can only be developed when an Rh-negative patient is exposed to Rh-positive blood. This can only happen through pregnancy and or a red blood cell transfusion. Why is developing an anti-D a problem? It can cause hemolytic disease of the fetal newborn in subsequent pregnancies. This is why giving Winrow to Rh-negative mothers is so important to prevent the development of an anti-D. It can also complicate future red blood cell transfusions. That being said, just because a Rh-negative patient received an Rh-positive unit of blood doesn't mean that that patient will definitely develop an anti-D. Whether someone forms antibodies or not depends on their own immune system. Some people are just more immunogenic than others. However, there's always the real possibility that an anti-D can develop, and if it does, it complicates future transfusions and future pregnancies, and it's usually not worth the risk. Alloantibodies. What is an alloantibody or an allogenic antibody? Allogenic antibodies are antibodies produced by the individual's immune system in response to foreign antigens in a previous transfusion of donor red blood cells or red cells introduced by crossing the placenta in pregnancy. ABO antigens are the strongest in the main category for blood typing, but there are many other antigens that a person can develop an antibody to. In this depiction, you can see that all these little shapes on the red cell surface represent different blood group systems. These are the main antibodies that transfusion medicine tests for, but not all. A phenotype is whether you lack or have these antigens. If you are negative or lack an antigen, you have the potential to develop the corresponding antibody if you were exposed to that antigen. This is the same concept as catching a cold. If you're introduced to a virus, your body creates an immune response, antibodies, so that if you're ever introduced to that virus again, your body will have a quicker immune response, taking the virus out of circulation. So why are these a problem? Why are they a problem for a patient? It is the same reaction as an allergy or a cold virus, but on your red cell. The antibodies formed will bind to the antigens on the donor red blood cell and mark the cell to be taken out of circulation. This causes hemolysis. So depending on how strong a patient's immune system is, this can happen in a delayed response or very rapidly, either way causing problems for the patient. Antibodies cause complications in finding compatible blood for patients, and some antibodies can cross the placenta and attack the fetus's red blood cells. Antibody testing. The basic antibody screen test performed by the transfusion medicine lab is designed to test for all clinically significant antibodies. If a patient has a negative antibody screen, they are eligible for any unit of red blood cells that is the same or compatible blood group. If the patient's antibody screen is positive, the technologist must perform additional testing to investigate and try to identify what is causing the positive reaction. This flowchart is a very simplified overview of the testing process and timelines for a sample with a positive antibody screen. In practice, the testing pathways may branch off into additional testing flowchart algorithms depending on the results of each test. Because of this, the time required to identify an antibody and find compatible blood can vary significantly, typically ranging from approximately 90 minutes to up to 24 hours, depending on the complexity and the antibody or antibodies identified. Therapy causing drug interference. Monoclonal antibodies are lab-made proteins that act like human antibodies in the immune system. They are designed to bind specific antigens to treat many different disease states. Monoclonal antibodies directly target the cancer cells and mark them for destruction by the immune system, or they block the growth of the cancer cells. These drugs can interfere with the antibody screen testing. Monoclonal antibodies target CD38 and CD47 and interfere with pre-transfusion antibody screen testing by binding to the antigens present on the reagent red blood cells, causing false positive reactions or panagglutination. When an antibody testing shows panagglutination, every cell reacts positively. This makes it impossible to determine whether a patient has a true clinically significant antibody or if the reactions are caused by drug interference. Phenotyping. To help manage this, we perform patient phenotyping. Phenotyping identifies which clinically significant antigens are present or absent on a patient's red blood cells. Patients can form antibodies when exposed to antigens they lack. Similar to a patient's blood type, a person's phenotype does not change, so the testing only needs to be completed once. Phenotype testing can be done on a patient that has not been transfused in the last 3 months. Otherwise, phenotype tests could be falsely positive due to donor blood circulating their system. If phenotyping is completed before monoclonal antibody therapy begins, it allows the transfusions department to provide phenotype matched or phenospecific red blood cells once drug interference occurs. Providing phenotype matched units reduces risk of alloimmunization or developing an antibody because the donor red cells match the patient's own antigen profile, and therefore the immune system does not see the donor blood as foreign. Since patients cannot form antibodies against antigens that are present on their own red blood cells, matching the donor units in this way provides the safest transfusion option. Even though the drug interference prevents us from fully ruling out underlying antibodies, phenotype matched units minimize the likelihood that a clinically significant antibody is being missed. Blood administration. I just wanted to touch on this because there have been several incident reports over the last few months across the province. Transfusion of blood components must be completed within 4 hours from the time of removal from a temperature-controlled environment. Therefore, they must be infused with 4 hours from time of issue from the lab. Standards say that you have 60 minutes to spike a unit once it leaves cold storage, but then you have to remember that now you only have 3 hours to transfuse it. So be mindful, and it's always our suggestion not to go pick up the unit until you are actually ready to transfuse. Administration of blood products, however, such as albumin, must be completed within 4 hours of accessing the blood product vial, so from spiking the vial. If 4 hours has elapsed and the transfusion or infusion is not complete, the transfusion must be discontinued and the remaining blood component or product must be discarded. A memo went out last week about the blood issue and administration audit that will roll out February 15th. This is a provincially standardized audit process being implemented to support compliance with Canadian transfusion accreditation requirements. The audit is designed to monitor both lab and nursing practices, and this audit is intended to support quality improvement and not meant to be focused on fault finding. Its purpose is to ensure patients are receiving the safest and highest standard of care while also identifying opportunities for education and process improvement across the province. Transfusion reactions. Report everything. Transfusion reactions across Canada are severely underreported. Why? Many transfusion reaction symptoms look like other clinical issues. Fever, hypotension, tachycardia, respiratory distress, nausea, rigors, rash can all be attributed to many other disease states. There are often gaps in education or inconsistent training. Staff may be unaware of what qualifies as a reportable reaction, believe that only severe or obvious reactions need to be reported, underestimate mild or delayed reactions, like delayed hemolytic transfusion reactions or TACO or mild allergic reactions. Delayed and subtle reactions are often easily missed and or not transfusion enough to be able to see the signs and symptoms. Reporting can sometimes feel time consuming. People might fear blame or consequence that they did something wrong, or the belief that the patient is fine, so the reaction didn't really matter. The transfusion reaction bedside algorithm can be found on SHA's website under blood administration resources, clinical resources, and there are also lots of resources on the Sask Blood website under transfusion adverse events page. Transfusion reaction signs and symptoms. Mild reactions include fever and chills, greater than 1 degree temperature change, or a temperature of greater than 38 degrees Celsius. The feeling of cold and chills should be monitored for up to 4 hours post-transfusion. Skin reactions, allergic symptoms, restlessness or anxiety. This is a symptom of a reaction that gets missed a lot. If a patient has a general feeling that something is wrong, stop the transfusion. Headaches are often associated with IVIG. More severe reactions include breathing problems, pain, gastrointestinal distress, cardiovascular issues, and less common but very serious symptoms include changes in urine. Dark or reddish urine can be a symptom of hemolysis, bleeding, abnormal or heavy bleeding from the IV site or elsewhere, neurological changes, dizziness, restlessness, confusion. These are all reaction symptoms. What to do if you suspect a transfusion reaction. Stop the transfusion immediately. Start a new line of saline to keep the vein open. Take vital signs, including temperature. Ensure the patient is comfortable and start oxygen if required. Recheck the patient ID and the blood product or component tag. Making sure that there is no clerical error and the correct patient received the blood product is very important. Notify the ordering physician and the transfusions department. Do not continue the transfusion or disconnect the unit unless directed. It is the responsibility of the physician to decide if this is an adverse event. The physician may direct you to continue the transfusion after the administration of medication such as Tylenol or Benadryl. This is okay, and the reaction is still reportable if you stopped and treated and finished the transfusion. If the reaction is severe, always call the TMP on call. Administer drugs as ordered and complete the Saskatchewan Transfusion Adverse Events Report form. This form can be found on the SHA website, on the Transfusion Medicine homepage, or on the Sask Blood website under the Forms tab. Collect a post-transfusion sample, which is 2 EDTA lavender top tubes, and send everything to the transfusions department. Page 1 of the Sask TARE form, the blood component or the unit or the blood product vial, up the post-transfusion sample, and your nursing notes from. This is the Saskatchewan Transfusion Adverse Events Report form. It is 3 pages long. This is the first page. The healthcare provider completing the transfusion is responsible for completing every section on the first page and putting the patient's address graph on all 3 pages before sending it to the lab. The lab and the hematopathologist reviewing the reaction will fill out pages 2 and 3.